Kristen, it looked like it said transcription had, oh no, it looks like it's going. I thought it had just stopped, but it's working, the recording. Is it working for you okay?
Yep.
Okay, great. Can you hear me still?
Yes.
Okay, thank you.
Hey, Susan, can you hear me okay?
Yes, I can.
Thanks. It's 1 o'clock. I'll call to order the Green Mountain Care Board's hearing of April 3rd, 2024. We have 2 agenda items, a presentation relating to MVP's new non-standard Gold 4 plan. We have a potential vote noticed. And then we have the Copley mid-year budget modification request and a potential vote noted for that as well. I'll turn to Director Barrett for her report.
Thank you, Mr. Chair. I'm going to shut off my camera since I'm having some connectivity issues. Can you guys hear me? Okay. So in a scheduling update, we did add a meeting to this month's schedule at the very end of the month on April 29th to discuss the AHEAD model. I believe that's in the morning at 9 a.m. So please keep an eye on our schedule as we may be adding meetings. In addition, we have several public comment periods. We are still seeking public comment on the guidance on the assessment of the affordability and review of rates, basically our rate review program and guidance on affordability for those rates. And we would like to have those comments to the board by April 9th so that the board can have them before they take up the issue and vote on it. In addition, we have 2 ongoing public comment periods. The first is on our community engagement work per Act 167 and hospital sustainability. We plan to get back out in the next several months with hospitals and communities on that work. But in the meantime, we would love to hear from the public or any other stakeholders on their comments on the community engagement work. And then last but certainly not least, we are accepting comments on a potential next model with CMMI. That would at this time be comments on the potential AHEAD model. Any comments we receive, we do share those with AHS and the governor's office as they are leading those negotiations and the work on the current model. So with that, I'll turn it back to you, Mr. Chair.
Thank you. We have meeting minutes from March 27th and April 1st. I'll take up the March 27th. I move to approve the minutes from March 27th, 2024.
Second.
All in favor, say aye.
Aye.
Aye. And the minutes are approved unanimously. I move to approve the minutes of April 1st, 2024, just this Monday. Is there a second?
Second.
All in favor, say aye.
Aye.
Aye, and the minutes are approved. I'll turn it to Staff Attorney Laura Beliveau and Christine Smith, who's a Senior Benefit Specialist at MVP Healthcare, for the presentation on MVP's new non-standard gold plan.
Thank
Hi,
you.
good afternoon. Sorry, it took me a second to find my mute button there. Today, Christine Smith from MVP Healthcare will be presenting MVP's proposed change to its non-standard qualified health plan, specifically its gold plan offerings. Earlier this year, MVP notified DVA and DFR of proposed changes to its non-standard qualified health plan designs. DFR determined that several of those proposed design changes were minor modifications and do not require board approval. However, MVP is also presenting a proposal for a new plan design that does require board approval. They are proposing to discontinue one of its non-standard gold plans and introduce a new high deductible health plan, gold plan. The board has established criteria that it follows for determining whether a new non-standard plan design would add value to the Vermont marketplace. A vote has been noticed for this matter, and with that, I will turn it over to Christine Smith.
Thank you. I appreciate it. Laura, are you sharing the slideshow or am I sharing it?
I
I'm sharing-
think Kristen shares it,
Oh, okay.
but Kristen, speak up if I'm mistaken.
I have it available. I certainly can share it. No problem at all.
Okay, maybe that makes them.
I've got it.
Okay, great. Okay, great. Thank you.
Just let me know.
So I
when
just
need to
wanted-
advance.
Sure. So let me just introduce myself again. I'm Christine Smith from MVP. I am a senior benefit specialist in our commercial product area, responsible for Vermont small group and individual products. And today I'd like to talk to you a little bit about this new gold plan that we would like to introduce to the Vermont market and our reasons why. You can move ahead, Kristen. So I'm going to give you a little information about the trends that we're seeing in behavioral health issues, give you our portfolio updates, and introduce the new gold plan design. Our number one goal for 2025 for MVP was to improve behavioral health access for young people and adolescents. So we found that there were mental health concerns are continuing to grow with U.S. children and adolescents and young adults across all markets and in all areas. We already offer our GIA virtual care program that supports members with using Galileo through our product My Visit Now for $0 behavioral health visits, but they are virtual. And we do understand that in a lot of cases, virtual isn't the right fit for all members. So we wanted to take a step to go beyond the virtual. You can advance, Kristen. I'm not going to go through this, but this is basically some research that we did and where we got it from. So they're cited on behavioral health issues with children growing with a rapid increase. You can see ER visits from 2007 to 2016 increased at 120% at children's hospitals and 55% at general hospitals. So it has been in 2021, the U.S. Surgeon General did issue a warning that growing mental health crisis among children is a national emergency. This was specific to MVP's members. For the 10 to 19-year-olds commercial population from 2020 to 2023, the percent of the population with anxiety and fear-related disorders increased from 8.3 to 10.9%. Professional visits for the same condition increased from 302 out of 1,000 to 499 out of 1,000. and allowed the PMPM increase from 465 to 791. Increases will also in visits for depression disorders, trauma, stressor-related disorders, and all of these statistics point towards an escalating need for treatment where we already know that there are capacity and access issues. So our goals were to reduce the time between the identification of a concern and the start of the right treatment plan with the right provider. And this all came out of our EBI data. But the one that I really want to focus on is reducing the likelihood that cost share is a financial barrier to accessing the right care. So what was our plan to achieve that? So outside of our plan designs, we are also working on creating screenings and self-evaluation tools to guide members to the right kind of care and to appropriate providers. And we do have a plan design concept to reduce the financial barrier, and that was to add 3 outpatient in-person behavioral visits for all members to all of our non-high deductible plans. So in addition to adding this gold plan, you'll see in all of our non-standard plans for 2025, if they are not a high deductible, they have 3 PCP/mental health visits before the deductible covered in full. So again, these are just some of the value statements in what MVP was trying to accomplish. We want to improve our members' satisfaction with finding a behavioral health provider. We want to improve their engagement. We want to make sure that our compliance with treatment plans and quality of care by removing that financial barrier, and reduce the frequency and cost of emergency room visits by putting something in front of them that would allow them easier access at a less cost share. So this is the new Gold 4 plan that we are proposing. Just to show you, like, this is our membership from 1/1/2025. I'm sorry, 1/1/2024 compared to what it was in December. So you can see that our gold portfolio has taken the biggest hit. We also had a lot of members in that, and we've lost a significant amount. Now, some of those members may have moved down to a silver plan or a bronze plan, but overall our portfolio did decrease. So the evaluation criteria for the non-standard QHPs, the list of criteria is on the left-hand side. So substantiate the difference in deductible and/or maximum out of pocket compared to standard plans. There are no substantial differences with this plan, but the cost share differences for one or more highly utilized services compared to our standard plan designs. So in this new Gold 4 plan, PCP, including any services performed in a PCP office, which also includes mental health visits, specialist, including any services performed in a specialist office, urgent care, and tier 1 pharmacy will all be covered in full. The plan does not have a structure difference. From Enhances Innovation, the covered in full benefits are in response to the increase seen throughout the membership in behavioral health disorders. Removing some of the cost share for the benefits related to behavioral health disorders will hopefully reduce the likelihood that the cost share is the financial barrier to accessing the right care. And then I just cited that U.S. News and World Report article from 2023, how it would add value to the Vermont individual and small business health insurance market, because we do see a surge in the pediatric mental health emergencies that have overwhelmed ERs in the U.S. So this is like an overview of what the plan is going to look like. It will have a $5,000 deductible, which is higher than most gold plans. With an out-of-pocket maximum of $8,000 for an individual. Again, like I mentioned, PCP and mental health outpatient will be covered in full, so will specialist. ER is at $500 after deductible. Urgent care will be covered in full. Inpatient and skilled nursing will be at 20%. High-tech imaging MRIs will also be at $500 after deductible. PT, OT, and ST PT will be $25 with no deductible, and then OT-ST will be $50 after deductible. And then lab and X-ray will both be $50, no deductible, if done at an outpatient facility. So if they're inpatient, they will have to cover the deductible as well. Our outpatient facility is 1,000 after deductible. Outpatient surgical services are at 500. There is an RX deductible. It's a brand deductible only. It's $250 for an individual. And then tier 1, tier 2, and tier 3 are going to be covered in full, then $40, then $80. So this plan would be priced as our lowest cost gold plan, but would have to replace an existing gold plan that we have in our non-standard portfolio today. And because our other gold plan is a high deductible plan, and I'm sorry, Laura did say at the beginning that this is a high deductible plan. It actually is not, because we have a lot of services that are not required to hit the deductible. But this plan would be replacing our other non-high deductible plan, which is our Gold 2, where we have currently 353 members in that plan across small group and individual. We're going to suggest that we would map these members to the standard Gold 1 plan, because we wouldn't want to map them to our gold, non-standard gold plan, because that is a high deductible. And if a member has chosen a non-high deductible, chances are that is not really what fits their needs. So we think that the standard Gold 1 is the best mapping option for these members. And this is what the current Gold 2 plan that our members are in today looks like versus what the 2025 standard Gold 1 plan would look like. So the deductible now they have is $850. The standard plan's at $1,400. The out-of-pocket max is $6,600 and the standard has $5,600. They both have a $20 not subject to deductible PCP mental health, but the new Gold 1 is going to include the 3 visits covered in full. The specialist is $45 now, not subject to deductible. It will be going to $55. Ambulance goes up $25, but no deductible. ER actually goes down $100. And then inpatient, outpatient, which are at co-insurance today, would go from 20% to 30%. And then X-ray and lab, which are for us today, co-pays would go to the 30% co-insurance. RX is similar. It's $15, no deductible, 50%. It would be going to $15, no deductible, 50% with a brand deductible. On our plan today, it's $350. On the standard plan, $200. And the RX out-of-pocket max at $1,500 would go up to $1,600. But also, I just wanted to mention that this is the 2024 model of the Gold 2, which some of these things would probably be changing for 2025 anyway. If they were to stay in this plan, we know the RX out-of-pocket max would be going up to $1,600, and we may have to make some other adjustments depending on the AB calculator. So I'm going to pause there before I go into the other product to see if anybody has any questions on the Gold 4 or in our mapping decision.
Could you just give me an example of, you said a $1,000 out-of-pocket outpatient facility charge on the new Gold 4? What is it? Can you give me an example of an outpatient facility charge?
That's like ambulatory surgery. So if you go in for a surgery that you're in and out in the same day, that's an outpatient surgery. The facility charge would be $1,000 for that facility. And then there's a surgical fee as well, which would be $1,500, well, $500.
Okay, thanks.
Okay, if there's no other questions, Kristen, we can keep going. So just to show you some of our other 2025 product portfolio updates, and these were changes due to AB. And let me preface that it's due to the AB plus our decision to do the 3 visits. It's covered in full for all of our non-high deductible plans. So for the non-standard Gold 2, if the Gold 4 is not approved, this is what the new plan will look like. So the deductible will stay. The out-of-pocket max will actually be reduced to $6,250 from $6,600. You can see that we did add those 3 visits at 0, no deductible. and then a 25 no deductible PCP mental health. No change to any of the other core benefits with the exception of tier 3 pharmacy. Another thing that MVP has been trying to do when we can and it makes sense is to remove coinsurance and replace it with copays, because we've gotten a lot of feedback from our members that coinsurance is confusing. So we are trying where we can and where it makes sense and doesn't make a huge dent in their premium for us to do so, change over some of our coinsurances to copays. And this was one example of changing the 50% tier 3 to a $60 copay for the after a $350 brand deductible made sense, and then moving the RX out of pocket up to $1,600. Our Silver One and our Silver One Reflective are also going to have some changes. Out of pocket max is going to go up $100, and that was basically due to us adding the first 3 visits at 0 no deductible, so that we could keep it in AV. The outpatient is going to go from $400 to $1,500. And again, we changed that coinsurance on tier 2 and tier 3 from 50% to $30 and $60, with the RX out of pocket max moving up to $1,600. Our Bronze One plan, again, we added those first 3 visits. The AV was kind to us with this plan and allowed us to leave our deductible out of pocket max as is with doing that. We also were able to switch our pharmacy around a little, and whenever we can make the pharmacy more affordable for members without having, like I said, a major impact to their premium, as well as keeping it in the AV level, we'd like to do that. So for this plan, tier 1 will go from $25 to $10. Tier 2 will go from $100 to $50, and tier 3 will go from 60% coinsurance to an $80 copay after the brand deductible of $700. And our Bronze 5. And these changes from the $94.50 to the $92.00 were because of the federal regulation that you couldn't have a plan with a higher out-of-pocket or deductible of $9,200. So we bumped that one down. And with that, we also made the change to the tier 1 of the RX in this plan. So this plan already had first 3 visits at 0 no deductible, so we didn't have to add that, but we did change the tier 1 from 35 no deductible down to 10, and left this plan is matching deductible out of pocket max, so everything else is 0% after deductible. And that's basically what our non-standard portfolio is going to look like. Those are any changes. Other plans that are in our portfolio will remain. There were no changes to. So if you have any questions, please, I'd love to answer them for you. I also just wanted to add that I do have Eric Bachner on the line with us as well from MVP's actuarial area. So if there were any actuarial questions, he's here to support me as well.
I have a quick question, if I can go ahead and jump in. Are you concerned at all with being able to explain or message the visits that are covered pre-deductible to consumers?
That is going to be one of our marketing campaigns for 2025, is so that members do know that we are offering this year. We're trying to do it across our Vermont and New York membership. So it's going to be something that we're going to really be focusing on this year.
Thanks.
Hi, Christine, it's Tom. Excuse me. Thank you for the presentation. It's a lot of information, and I was trying to remember the values that you talked about in the first few slides, and then link it to the changes in the plans as you went along. It was a bit difficult at times, but what I see, the key change are the 3 fully covered visits pre-deductible. Are there other changes that are helping kids and adolescents get the care they need when they need it?
Yes, so I'm glad you asked that question, because in addition to the PCP mental health visits that we're covering in full, We did throw urgent care in there because we are seeing that, a lot of, if they can't get an appointment into a PCP or a mental health, or a mental health provider, they're immediately going to an ER. And we want to discourage those ER visits, one, because it's probably not the best place for adolescents to go. And so we put urgent care in there because we feel like that's a good pathway between a PCP visit and an ER visit so that they have access to that covered in full as well. And we know that urgent care centers are everywhere these days. So they are, and you don't have to make an appointment. So it does give them the access that we're hoping to give them.
Yeah. And so some of the other changes in the rows are, and I don't know another way to describe it, but that I'm worried about seeming to be impolite, and I don't mean to, but the other changes in the rows allow you to afford adding the 3 visits and making urgent care more affordable. Is that correct?
Yeah. So,
Okay.
yes, you're correct. That's why
Yep.
like outpatient is higher. And yes, and like ER is 500. We're also, like I said, 500 is a little more of a deterrence than a $200 ER visit. So, I can go to urgent care for free versus paying $500. That's hopefully gonna be a decision maker for us.
Yeah.
So that's what we were hoping for.
Okay.
There is going to be a specific market for this plan. There's, plan is not going to be for everyone. With a
Right.
gold plan and a $5,000 deductible, it's not everybody's plan. But if you fit the right criteria to use the benefits that we're covering in full, it's a great plan because it's also the lowest cost gold plan as well.
Right. And that's where a lot of people, it's a lot of people make the decision based on the premium, right? And they don't read through more of the details. So the marketing campaign that you talked about to let people know what you're encouraging and discouraging, I think is going to be key. But I appreciate what you're trying to do.
Thank you.
I really do. So thank you.
This is Jessica Holmes. Nice to see you. Thank you for coming. I also appreciate the emphasis on increasing access to mental health providers. I think, you spot on the data certainly shows access has been a challenge, and also, incidence rates have been rising over time. So I'm wondering if you have data on the percent of licensed and active mental health providers in Vermont that accept MVP and how that percentage has changed over time as we're thinking
So
about
that's
access.
That's a great question. And I do not have that available to me, but I know our clinical team has been working on that exact question. So I could get that information for you guys if it's something that you'd like me to follow up with. Absolutely.
I would
but yes,
love to. That would be fantastic. And I'd also just love to hear, or maybe the clinical team also has any information on how the reimbursement rates for MVP might compare to other commercial insurers. Is it, how do you benchmark yourself, and where do you land in terms of the reimbursements to mental health? Because I'm thinking access is lots of different, components to it. And so,
Sure.
First of all is making sure that providers are accepting MVP. Will certainly be important in achieving the aims here. So if you have any information on that, I'd appreciate it. But I really appreciate your presentation today. Thank you.
Thank you.
Appreciate it as well. Go ahead.
I was just gonna say, Jessica, is that some information that I could funnel back through Laura?
I think Laura would be a perfect person for that. Yeah,
Okay,
if Laura's
great.
so willing.
Okay, thank you.
I just have one question that's probably not plan specific. It's probably all plans. But if a patient goes to an urgent care and then gets told that they need to go to the emergency department, do they then have to pay the $500 copay to go to the ED because if they were instructed by the urgent care to go there?
Yes, they would.
Okay.
If you have to go to the ER, you're going to have to go to the ER. That's going to be the same no matter what plan design you're in. But I think people pull the trigger a little quickly on going to the ER, and this is trying to help steer them to another facility. If it's not, obviously if if you're having a heart attack or something that's critical that we know that you need to go to an ER, we're not discouraging that. But for the most part, you know, people do tend to run to the ER rather than go through an urgent care facility. And this will hopefully give them that, try to start changing their minds about, you know, where they choose to go first. So, you know, and any urgent care will tell you, like, you know, if this is an emergency, go to the emergency room. But it shouldn't be the first pass every time. You know, there should be other options. And we're hoping that the covered in full visit to the urgent care turns a light on and says, oh, let me try urgent care. You know, it's 3 o'clock in the morning and my daughter has an ear infection. I don't really need to go to the ER, but I want to get her seen. So let me take her to the urgent care.
I don't think in Vermont we have any urgent cares open at 3 o'clock in the morning.
I'm sorry.
Most close at 5 or 6 p.m.
Okay.
So we have, for the most part, yeah, 9 to 5 is sort of the.
Well,
urgent
let's
care
work to
availability.
change that in Vermont too. Come on, guys,
Yeah.
let's go.
Work on that.
I had no questions, just related to what Dave and Tom said. Do you see these incentive changes drive the behavior as much as you anticipate? I mean, I agree with the logic and the notion and the effort, and think it's really great that you're doing this. Do you typically see this pulling through?
Well, what we're hearing from our members through our customer satisfaction surveys and focus groups that we've had is that cost is a barrier. So I think removing the cost for some of these services will be a factor to change behavior. That's what we're hoping for. So do we have it proven yet? No, we're just listening to what our members are asking for. They're telling us that, you know, sometimes they don't seek treatment because of a cost factor. And so by us removing that barrier, we're hoping to get people the treatment that they need.
Yeah, and that's just a question of, is it like a writ large cost factor, so they don't go to like care as much as possible, or is it specific to like particular care settings?
No, our clinical team is saying that behavioral health issues are not being treated at all because people are not seeking care, and largely because of they don't want to pay to go to any kind of provider. So we're hoping that this gets their foot in the door to get them the care that they need.
Great. Well, I really appreciate the innovation and the effort in this important area, so I'm happy to see it. I'll turn to the healthcare advocate for any questions or comments they may have.
Yeah, hi. So Charles Becker here for the healthcare advocate. If I could just start with a question, just to pivot off of Member Walsh's questions. I just want to make sure I understand the new Gold 4 plan correctly. So it's on the new Gold 4 plan. It's more than just 3 free primary care visits and mental health visits and
Yes.
urgent care visits. It's
All
unlimited, right?
correct.
Okay.
That is correct.
Okay.
It's the other plans that we put the 3 visits in if they weren't a high deductible plan, but this one is all.
Okay, perfect. Thank you. So then with that, I mean, I'd just like to commend MVP for attempting to find a solution to a problem that their members are facing, and leaving aside whether their solution will actually promote access when there's a shortage of primary care physicians and when there's a shortage of mental health professionals. Also leaving aside that $5,000 deductible, which might create its own set of access issues. We do think, as Ms. Smith said, that for some people, the trade-off of that high deductible in exchange for unlimited, covered in full primary care visits, mental health visits, urgent care, tier 1 medications, that trade-off might be worth it for some people. And in a year when we're hoping to encourage people to shift to gold plans, MVP's new gold plan is an interesting alternative and would seem to add value. So we don't object to the board approving this plan. Thank you.
Thank
That's
you.
all I had. Yep.
Thank you.
Thank you.
We have a potential vote noticed. Do board members feel as though they would be ready to vote today? And then second, do we have potential motion language or? Okay. I'm ready to vote, and it looks like the other board members are. So I'll go ahead and make the motion, and then we'll take public comment after the motion, if there's a second for the motion. So I move to approve MVP's proposal to discontinue its non-standard Gold 2 plan and add the non-standard Gold 4 plan to its non-standard QHP offerings.
Second.
I'll second.
Thank you. And I'll open up to public comment via the raise the hand function. Hey, Walter, how are you?
Hey, oh no, waiting for another blizzard. Another 3 or 4 foot blizzard coming.
I'm glad we're having this hearing today, not tomorrow.
Oh, yeah, I know. I'll be at work for the next 14 days straight. Just a couple things. Speaking as a patient and speaking as someone who works out on the front lines for a living, I'm curious if this plan, when they talked about urgent care, ER, trying to steer you, is this a managed care plan? And again, I wanted to echo the advocates that $5,000 deductibles, how many people can actually afford that? And I've also always had this dream that the insurance people who dream up these plans should have to live under them. And I think that people should have to live under this plan. Because it's, you know, it's really complicated.
Ms. Smith, it might be easy enough for you to respond if you're willing to the question about the managed care that Mr. Carpenter had.
No, I wouldn't say it's managed care. It's more of a learning, trying to educate members of what's out there as far as pathways to gain access. We're not trying to manage how people go, see providers, just trying to give them some alternatives and remove the cost barrier in doing so.
Great, thank you. Any other public comment? I think we're ready to vote. All those in favor of the motion, please say aye.
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 Aye. And the motion carries. Ms. Smith, thank you very much for your presentation and answering our questions, and thank you very much, Laura.
Thank you for having me. Thank you very much.
Next agenda item is the Copley mid-year budget modification request. We've had this on our calendar, I think, 2 prior weeks, and additionally, we had the presentation. So thanks everyone for their patience on this as we did a little bit more diligence at the staff level. I'll turn it to Mr. Sutter and Mr. McCracken.
Thanks, Chair Foster. Let me get the presentation loaded. Can you all see that? Fine. Okay, so real quick, just a quick agenda. I'm going to recap Copley's Hospital's request. Just a quick summary of some slides that we reviewed last time we presented. Then we're going to go over staff analysis of some key financial ratios related to the request. Reintroduce statutory criteria needed for potential budget modification or budget modifications, and then potentially hold a vote. So just as a reminder, Copley's request was for a 12.7% increase on their 8% approved change in charge for the year. Their finance committee approved the request in late January, and the board received it in February, along with other materials. On the right of this slide, you can see a condensed income statement showing their budget as approved, their current projections for the year, and the projections with their 12.7% rate increase. The reason for the request is the approved change in charge will not generate budgeted revenues given the utilization projections, essentially. Current projections have Copley generating about a negative 2.8% operating margin for FY24. And in the small table below, you can see what that results in about for days cash on hand. So jumping to some financial ratios, we wanted to take a look at change in net assets. There was some discussion about Copley in the context of what we had seen with Springfield, another hospital that had some negative operating results or income results. So looking at hospitals year over year, change in net assets as a percentage of their total assets kind of allows us to get a similar size or common size for comparison purposes. So if you crunch the numbers and without a rate increase, Copley's 24 change in assets for total assets would be projected at negative 3.67. And if you look at the table to the left, they're consistently at some of the most negative relative changes to net assets. I think they're also, if you see from FY18 to FY20, the only hospital other than Springfield with 3 consecutive negative figures there. This is basically the same data, just showing Springfield and Copley. Springfield in the years with the run up to their bankruptcy. I didn't include future years for Springfield because it makes the graph kind of unreadable. It spikes again, just the nature of the percentage change. But the green line is Springfield, yellow line Copley, and then the blue line extending off of 23 would be the projection for this figure with the full rate request. If we jump, If we jump to days cash on hand, I graphed that. I looked at all the critical access hospitals, and then the dotted line is just this total system average for days cash on hand. You can see Copley is now the lowest among the critical access hospitals by this measure. I believe they're also the lowest among all hospitals in the system, other than Springfield, which has a different structure with their parent organization holding their cash. They always look unusually low on these measures. If we take a look at long-term debt to asset comparison, long-term debt to asset comparison, it kind of it's a ratio that kind of looks the extent the organization's using borrowed funds to finance assets. It's not entirely useful in isolation, but it can kind of tell us something about their capital structure. And compared to the system-wide, you're kind of seeing this ratio fall, but you're again seeing it fall faster for Copley. So again, in isolation, this doesn't really tell us a whole lot, but it may suggest an increasing unwillingness or inability to borrow. The last ratio is a little bit more useful when considered looking at some other ratios. So this is cash to long-term debt. It's a ratio of their debt to available cash and investments. So just for a way to read the number, as an example, a hospital with $100 cash and investments and $50 worth of long-term debt, the ratio would be about 2. And as you can see, the dotted line, that's about what the system average is. Copley's cash to long-term debt is the lowest in the system, other than Southwestern Vermont, which again, when we're looking at cash, kind of usually is an outlier for explainable reasons. But Copley's cash to long-term debt is now very low relative to the system. And finally, they look a little bit better on age of plant compared to the system. But I did want to mention that this is a measure of financial age of the hospital. So it's the accumulated depreciation as a ratio over depreciation expense. So this can be affected by, like, let's say you have a capital item with a large amount of accumulated depreciation that falls off of your balance sheet. The age of plant can be affected dramatically by that. And I think that's what's going on if you see Porter in FY23. So those are some ratios we looked at for context, especially in relation to other hospitals in the system. Last time we presented, we also discussed or showed their submitted versus approved change in charge alongside their actual operating margins for that fiscal year. And you can see basically since 2016, they were about break even in 2016, but with the exception of FY21 with some COVID, I believe it was grant funding or COVID funding, that they've been chronically running negative operating margins. So I'll pass it over to Russ really quickly to again go over the statute, rule, and policy associated with mid-year rate requests.
Great, thanks, Matt. For board members, you've seen this slide before. We presented it a couple of meetings ago. So I'll run through it again here. Under the statute governing hospital budgets, 9456F tells the board that you can, upon request of the hospital, adjust a budget upon a showing of need based upon exceptional or unforeseen circumstances. So that's the threshold and the standard that we're looking at here. We also looked at Board Rule 3.401, which covers adjustments to established budgets, and it lists a couple of factors that the board should take into account. Includes the variability of a hospital's revenue, the hospital's ability to limit services to meet its budget, consistent with its obligation to provide appropriate care for all patients, the financial position of the hospital in relation to other hospitals and the healthcare system as a whole, hospitals' performance under budgets previously established, and any other considerations deemed appropriate by the board. And that's sort of carried through in the budget amendments and adjustments policy.
Thanks, Russ. So looking at their request in their hospital in context, we think there may be case to be made for exceptional circumstances. They have chronically negative operating margins. The reduced days cash on hand, the lowest among the critical access hospitals. We look at some of, sorry. If we look at some of their capital ratios, we're seeing possibly some reduced capacity to borrow. They have low debt to assets ratio, which on its own isn't necessarily a good or bad thing, but the second to lowest cash to long-term debt in the system of 1.2, where the system average was 2. And then, as we discussed at the last presentation, we're seeing some evidence that they have low prices relative to other Vermont hospitals. So in terms of potential options, we put 4 here. So option 1, just to go through quickly, is approve Copley's amended budget as submitted. This would mean a 12.7% increase from their rate in the budget, would generate approximately a 3% margin and get their days cash on hand up to almost 60. And then the column on the far right shows what that would represent, basically the impact of that on the system-wide average change in charge. So because Copley's budget relative to the system is quite small, it has a correspondingly small increase on the average, like the weighted change in charge in the system. Option 2 would be to approve a smaller rate increase calculated to generate approximately 0% margin. That'd be a 5.9% increase. And then option 3 is similar to option 2, except we're estimating the losses from October through February and saying what's the margin you would need, what's the rate increase you would need to generate effectively a 0% margin, but for those losses in those 5 months. And then option 4 would be to deny them a rate increase. In addition, while there's evidence, as I mentioned, that Copley's prices are low compared to the system, there's also evidence that their expense growth has outpaced other Vermont critical access hospitals. And you can see that in slide 8 and from our prior presentation, which is linked here. Should the board approve a rate increase, staff recommends requiring Copley to provide the board with a 3-year projection of expenses, the final form to be determined by staff, which will include discussion explanations of key drivers of expected growth and management strategy for controlling or mitigating that growth. Past that, before we get to the potential vote, I just want to mention in the appendix, I've included calculations for our figures shown today. If you want to recreate those. And then also I added a table that kind of shows their operating margin, the additional rate we need project for them to hit that margin, and then similar to that option 3, where if we had them carry the approximate losses from October to February, that operating margin, but for those losses. So we have some suggested motion language. Should the board choose to approve the rate increase, which would be But I don't know that I necessarily need to read it yet, but
Yeah, Matt, if you don't mind, I'll just
yeah,
jump
thank you.
in. And we have some suggested motion language will obviously need to be modified or changed depending on the board's decision here. We have some placeholders in that. I also wanted to note that it's a little bit lengthy in some of this, but essentially what we're saying is that if the board approves a mid-year rate increase, that's going to be reflected in a amendment to the budget order with conditions around that rate increase that follow the same language that we have in the current budget order. So the overall change in charging commercial rate increase is approved at not more than whatever percent over the previously approved FY24 levels, with no commercial rate increase for any payer at more than that same percentage over the current approved levels. The rate increase with respect to any payer might be less than that amount is negotiated between the hospital and the payer, and it's a cap and not a guaranteed amount. So I just wanted to explain why the motion language here is a little bit lengthy. I'm trying to capture the fact that we're going to carry forward the formulation of those conditions into any modified order. And so I think we're going to turn it, unless Matt, you had something else to add, we're going to turn it back to the board for questions, comments, and discussion.
Thank you both. I'll open up to the other board members.
I do have one question. So in thinking about the percentage of the rate increase, is that the annualized amount, meaning that so in the following year, the whatever percentage would be baked in at that percentage, or is that a percentage for the remaining time in the calendar year or whatever the contract year, I guess, is?
I believe the increase would be baked in for perpetuity. So in next year's budget decisions, it would be, you'd have to be considering that increase as well.
Right, but it is annualized, right? Because they
Yeah.
obviously won't be able to get the full amount of money attached to an annual figure midway through.
Right.
Okay, thank you. Just wanted to, I thought so. I just wanted to clarify because I have a vague recollection that that was an issue in a previous mid-year.
I'll jump in. So I am in agreement that, or at least I agree with the staff's assessment that their Copley's situation is where they have a financial position related to other hospitals that leads to exceptional circumstances, and I'm comfortable with, I think it's appropriate to give a mid-year budget adjustment. From my view, I think that through the RAND prices, both RAND 3 and 4, Copley has been at the low end of those prices. And despite, I think, a few slides after this, there's a slide that shows in the appendix a pretty high charge growth increase, really starting at 2019. That it's a low charge to begin the increase from, and with negative rate increases for a few years prior to that, and the RAND prices that came in around that time, I think if you project off of the RAND prices, both 3 and 4, they still end up pretty low comparative to other hospitals in Vermont. There are hospitals nationally that have lower prices, but comparatively speaking, they are a relatively low cost provider with seemingly generally great views on quality. I am concerned about their low days cash on hand and their inability to borrow. If we have a low cost provider who can provide care, we want them to be able to potentially expand their ability to provide care and keep a large market share of low cost care. I think the one complicating factor to me in this is there's two, is the operating expense growth, which appears relatively high. And I think this may be, again, a question of what is the base. And so we look at the NASHP cost tool per discharge, Copley is pretty low. So it's hard to say exactly of what their base expenses are relative to where their peers are and what they should be. But I think that high expense growth mirroring the high charge growth may be related to a lower baseline expense and some adjustments that are occurring to just manage being in the market. But I think learning more about that would be helpful. So what of these options would I be most comfortable with or feel is appropriate? I'm somewhere between options 1 and 2. I don't think we need to go all the way to option 1 at this point on a mid-year adjustment. And I would say, I think we should at least do an option 2 to try to get some feet back on the ground to be able to move towards a position where they can have more success in being able to borrow money. We talk a lot about bond covenants in various other hospitals. But I think that would be a healthier place for Copley to be for Vermont.
I agree with the points that Dr. Merman just made. I think Copley should be lauded for its excellent outcomes and low prices, but they need high enough prices to stay in business. And so I too am worried about the expense growth. I think the conditions that were laid out in the presentation would help us understand better what's driving that expense growth, the operating expense growth. I too fall in between option 1 and option 2. I think aiming for no margin, no operating margin seems a bit low. So I haven't done the math that's included in the appendices later on, but I've probably somewhere around 7%, just to start with a number.
Member Holmes or Lunch? I'm the chair, so I get to choose to go last.
Only if we come off mute.
You're gonna have to come off mute at some point.
That's true. So coming into the meeting, I would say I was somewhere between options 2 and 3. I think it's, I agree that a 0% margin is not sort of where we want to aspire to, but I think what we've seen in prior mid-years and prior budget hearings is that moving from the negative margin into the positive takes time, even particularly with the mid-year rate adjustment, because there will need to be time for things to be operationalized. kind of hearing where other folks are. I definitely am comfortable with option 2, and I need to think a little more if folks are moving higher than that. So I'll sit here and think while others speak. But in general, for the rationale, I'm comfortable and agree with what others have said.
Sure. So I support the findings that the negative margins, the low days cash on hand, the low prices in particular, together qualify as exceptional circumstances for a mid-year review. So I'm comfortable with that finding, which I think is an important one to start with. I can support option 2, getting them to a margin of 0 as a stopgap measure in a mid-year rate review adjustment. Mid-year adjustment. We don't have the same level of scrutiny that we do in a formal whole budget process. And whatever rate increase we support now carries on indefinitely. So I can support option 2. I think it's important to get them to a 0% margin. I would also caution, though, that it's a commercial rates increased ceiling. It's still subject to negotiation with the carriers. So it's, as I think the language said, it's not a Green Mountain Care Board mandate or guarantee. So I think it's important that we say that and acknowledge that. I appreciated the emphasis of others on understanding the operational expense growth that we're seeing from Copley. I think the language, the additional, if you can pull up that slide that had the additional considerations around forward-looking, understanding, projections of expenses. I actually would also want to, I would want an unpacking of the last 2 or 3 years to understand why the expense growth seem to exceed that of other critical access hospitals. I think we can learn a lot from that and hopefully understand that. And so I would also just ask for a look back analysis as well, comparable to what was happening with other critical access hospitals. So that's where I'm right now, but I'm open to hearing from others as well and continuing this conversation.
As to the threshold issues, I think there's 3 findings that have to be made, a showing of need, and then unforeseen circumstances or exceptional disjunctive. I think the first one, showing of need, has been demonstrated here by the presentations from Copley. I do not think unforeseen circumstances has been presented. These were foreseen. These were in the budget. We anticipated, Copley correctly anticipated the challenges it would have if it did not receive the rate it requested. But I do think that this qualifies for exceptional circumstances. So in terms of the threshold legal findings, I think Copley's submission qualifies. This is probably sort of at the lower range for me of what qualifies for exceptional. Simply needing to make margin is not alone enough to justify rate increases. But here, for the points that members Merman and others have made, this is a hospital that we are worried about. 39, 45 days cash on hand is very low. And this is a hospital that's been working really hard in a number of ways. And I thought Copley's representations and evidence and the staff's relating to the low cost aspect of this makes me comfortable that we should indeed provide a mid-year bump. Mid-year bumps are exceptional and extraordinary. So I think this is one that qualifies, but I don't anticipate seeing these frequently. There are a number of ways to get to margin. I just want to cite these. I know I'm not trying to lecture anybody, but volume is certainly one, expense control is one, Medicaid bumps is one, money from the state in other capacities is another. Those are more progressive ways to receive increases, whereas rate increases on a small amount of commercial is regressive. And so I worry a little bit about the policy behind that. But because Copley's prices have been so low, and they have been, I support an increase to get them to the right, to be able to keep going and try and keep improving as they have been. I would support the 5.9%, the 0.0 targeted margin. The reason I wouldn't necessarily go higher at this point, although I'm open-minded, is that this is a stopgap and that we have significant transformation work underway. My worry is that this is going to be something that we have a lot with a lot of hospitals where there's just significant commercial need across the board. We had 8 hospitals last year with negative margins, and we can't just rely on commercial to solve it. So for a stopgap to keep things working well, I approve it. I would approve a 0.0 margin and a 5.9% increase. But to me, this really just highlights the need for system-wide transformation, not particular to Copley, but for the system. We know that some of their problems that are hurting their finances deal with the boarding situation and with problems with reimbursements from Medicaid or Medicare. So these more structural system-wide problems are causing problems for Copley, and I want them to be able to keep trying to find solutions with us and the state. So it sounds like we have 2 board members between 5.9 to 12.7, 3 board members that are more around 5.9, I think, if I'm taking away what everyone said correctly.
I don't want to
I
rush
guess-
folks, but I'm happy to make a motion if we're ready for that. Oh, I see Russ raised his hand.
Sorry, I think before you do make a motion, Matt, if you could go back to the recommendation slide. I want to I guess a clarifying question or clarifying observation maybe. But I'll frame it as a question. Matt, when you do the calculation here to get to an operating margin, say of 0, taking option 2, that's assuming the rate increase goes into effect as of March 1st, is that right?
Yeah, it's using all the same assumptions from their submission.
Okay.
So I believe it was March, but I think Copley might have to speak more to that.
Okay, so it's not called out specifically in the motion language, although it could be added. But I think what we're sort of embedded in the staff recommendation, if the board goes that way, is that you're approving that rate increase as of March 1st. Or another date if you choose another date, but I just wanted to sort of clarify how the math was working on this slide.
Is there any issue with approving it now as to March 1st for the feasibility of obtaining that increase on bills that have already gone out? I guess, Mr. Wooden, you might know.
Yeah, we tried. Bills don't all go out at the same time, so there are bills that are probably already in transit being mailed. So it would have been nice, and I will sort of blame ourselves if we got more of this to you earlier, so that we would be talking about it earlier. So it will realize maybe half of March. You know, it's an estimate. Just because it's April 4th, 3rd, sorry.
I think I would be, along with Tom, comfortable with a 7%. And I calculate, I'm not exactly sure where that would end up with margin. I think given that we're probably going to be missing a month of margin, there we go. Can we calculate that out? It'd be
like 0.5%.
0.5% margin, so it's greater than 0. It'll probably, if utilization stayed flat with the bills going out later, it probably would be closer to 0. But if it was that, and I did a quick sort of calculation, that would affect the overall commercial expense in Vermont by, do I get 0.18%? So that's a very low impact to the total state, but actually has a potentially significantly stabilizing effect towards the healthcare delivery in a region of the state.
I also think, given the uncertainty about getting to 0, if we approve a number to only get to 0, there's still quite a likelihood they don't get there, and that will affect their borrowing power substantially, where being just on the other side of 0 paints a different picture. I think looking at the change in charge chart in the presentation, pictures can be misleading, but that picture looks as though we've cut Copley rather substantially compared to what they've requested over several years. And a 7% increase now added to the 8 that we approved previously gets them to 15, not for the full year, but for some of it. And they requested 15 from us last summer.
I guess I'm not persuaded by that because part of those cuts were enforcement at the time. And since 2021, we're at 28% rate increases approved. So it's not like we have not been making up even from those enforcement cuts since 2021. But, I recognize what everyone says. I think for me, what's challenging is the mid-year, to the chair's point.
Two responses to Dr. Merman and Member Walsh, their points. So Dave made a point about we already missed half of March. So if the idea is you want them near 0 margin just to get them on a better path at this point, they're going to have a little bit of time to effectuate this change too, and to negotiate this change, and then get into actually in the bank. So between now, if it's approved, and then it probably needs to be a little bit higher to target to 0 margin, right? And then I would also just observe that Copley's budgeting has been pretty accurate, and I appreciated that. I think with some of the potential enforcement matters we have coming down the pike, we saw hospitals wildly off in fiscal year 23 and potentially even 24 in some of the budgeting. So I wanted to recognize that Copley's budgeting has been, at least in my limited time at the board, fair and reasonable. So it sounds like, go ahead, Dave.
No, I was just going to ask Matt to go to the last slide in the appendix for a second.
I'm sorry, Dr. Moore, was that the Rand Price slide?
Yeah.
I think it was pulled out. It was in the prior presentation. I'm sorry.
Okay, that's all right. Well, I think you could go to the hospital budget compare tool and see where Copley's prices were in 2018 to 2020. And so I think if we apply 21% to that, they're still remarkably low. So I don't think that it's a different scenario than if a hospital that came in with higher prices is coming in and asking, and and saying that we need more rate to get to a a break-even margin. I think we're in a very different scenario with Copley than most other hospitals in the state.
So I would be supportive of 7.0. I think in light of the fact that there is going to be some time to get this through, it still targets a 0 break-even margin. And also it has a very minor impact on affordability. And I think that Copley made the point in their presentation that given their low costs, even if we add a small amount of additional cost to ratepayers, it increases our options for an affordable option in our healthcare system. So I would be willing to go to a 7% mid-year. It's an exceptional circumstance. This is not something I anticipate seeing again. And I hope that we all recognize the need that we have for transformation, because relying on commercial rate in a dwindling commercial population is not going to be an avenue that's always going to work for 14 hospitals in this state. So it sounds like we have 3 votes potentially around 7%. It's not the perfect solution for everybody, but I think we'll have 3 votes. And if you can put up the motion language, I'll make the motion. We'll see if there's a second, and then we can take public comment. So I move to approve a mid-year budget adjustment to Copley Hospital's fiscal year 24 budget with a charge and commercial rate increase of not more than 7% over Copley's previously approved fiscal year 24 budget, subject to the same conditions and limitations as set forth in Copley's fiscal year 24 budget order, including limitation on how charge and commercial rate increases are implemented as set out in conditions B and C, and with an additional condition requiring Copley to provide a 3-year projection of expenses in a format determined by GMCB staff.
Second.
I'll turn to the healthcare advocate for any comments they have.
Good afternoon. I think the board knows where we are, and we're not supportive of a rate increase. I want to thank everyone for the discussion. Then I'll just summarize by saying we really worry about the precedent that this sets, both about the process for how budgets are constructed and thought of, but also the standard by which they're evaluated in the mid-year. I do, however, want to raise up Member Holmes' comment that I'm not going to try to summarize, but relating to retrospectively looking at operating expense growth, I think that's a prudent idea worth considering. So thank you.
I appreciate the comment and have the similar concern regarding the precedent. Public comment via raise the hand. Well, thank you, staff and Copley, for your presentation. You can tell this was a difficult one a little bit for the board, and I think it's in recognition of how difficult our healthcare system is right now and how challenged it is from an affordability and sustainability standpoint, which is why we are all struggling a little bit. Those problems are real, and you can see it in how we have to think about these problems. So thank you for your submissions and in your presentations, and to the staff as well for helping guide us through this. I'll take a roll call vote. Mr.
Wait,
McCracken,
Owen?
could you do that?
Yes. Excuse me, Owen. Is it possible to make a
Yeah.
friendly amendment to this motion language that would require Copley to do the look back as well as the projection?
I think that would be fine.
I can support the 7%, but I really would like to see a little more deeper analysis of the relative growth in operating expenses.
It's a great point.
Mr. McCracken, would we take the vote with that friendly amendment included? Or do we need to do anything to recognize that in addition?
I believe you can accept the friendly amendment as the maker of the original motion.
The
And so
seconder
I
should
accept the friendly
also,
amendment.
the seconder should also be asked. At least that's how it always worked in the legislature.
Yes, thank you. Um,
I believe I was the seconder, and I would support the friendly amendment.
So I can take a roll call vote on the motion as modified by Member Holmes' friendly amendment. So I'll call the roll in alphabetical order. Member Holmes,
Yes.
Member Lunge,
Yes.
Member Merman,
Yes.
Member Walsh,
Yes.
and Chair Foster.
Yes. Okay. Thank you, everyone. Is there any old business or new business for the board? Oh, sorry, Mr. Wooden, I see your hand is raised.
Yeah, I didn't want to comment before the vote, thinking that inappropriate, but I do really appreciate everybody's effort with this. I know these things get really complicated. They do feel like they set patterns and precedents. There's a lot of variables that we all look at. It can be overwhelming because of so much information. So I want to thank everybody, and I will try to redouble my efforts in getting involved to help, because I think cutting down expenses and trying to manage the entire healthcare system is important. I inherited this job about 4.5 years ago, although I've known the history of Copley going back to 1999 when I was first CEO at Gifford. Many of you have inherited, the system, and we're all trying to make it better, but some of the history is relevant and some of it's not, and it's hard to determine which is which, but I appreciate that you guys have at least considered that. So I'm encouraged by your support, and I just want to express that. So thanks.
Thank you. Appreciate those remarks. And any old business or new, I'm sorry. There was a Howard.
Yeah, I just didn't catch that you read the whole motion that you voted on. Can you clarify what percentage you just voted on?
Oh, we voted unanimously to approve a 7% rate increase.
Okay, thank you. I don't know if you read that before it was voted on, but thank you.
We did.
I think I did.
Yep, you did.
Okay. I apologize. Thanks.
No problem. Is there any other questions or comments? Any old business or new business for the board? And I will move to adjourn.
Second.
All in favor, say aye.
Aye.
Right.
Aye.
Aye. We're adjourned. Have a nice day. Thank you.